We now have a brief chapter devoted to organ transplantation. Let me read vignette 1. A 62-year-old man who had a motorcycle accident has been in a coma for several weeks. He is on a respirator, has had pneumonia on and off, has been on vasopressors, and shows no signs of neurologic improvement. The family inquires about brain death and possible organ donation. You know, when organ transplantation began to be done, we were very fussy about who did we accept as an organ donor. The organ donor could not have any infections, could not be on vasopressors, had to be young. In fact, it had to be a very healthy person, except that person was brain dead. But the problem we confront in transplantation today is the enormous disparity between the number of organs that are available and the number of patients who need an organ. And there are something like, last time I checked, something like 65,000 people on a waiting list for a variety of transplants. And so the criteria to accept a donor has been liberalized tremendously, and very few blanket exclusions exist anymore. And in fact, the safe answer to give on the exam for this question is the harvesting team that works in that area should be called to evaluate the patient as a potential donor. They might reject the patient, but they should have an opportunity to do the evaluation rather than the treating physician a priori saying, this is not a suitable donor. I am aware presently of only one blanket exclusion. Now, this may change as things evolve, but I'm aware of only one blanket exclusion, and that is patients who are HIV positive. There is fear that if we transplant the virus from one person to another, that a mutation could be encouraged, and we might end up with a very virulent form of a virus and a pandemic. But other situations where you think, boy, that's not a good donor, we use. We take organs from donors who have hepatitis and give them to recipients who have the same type of hepatitis. Even a patient with metastatic cancer can donate corneas. So again, the answer is have this potential donor evaluated by a harvesting team. Now, this next several vignettes have to do with rejection of a solid organ that has been transplanted. And it would be helpful before we read them to have a little review of the topic, so let me do it. We're going to do this just chatting with each other. There are 3 types of organ rejection. The hyperacute rejection is due to preformed antibodies. It happens within minutes of establishing blood flow to the transplanted organ. For all practical purposes, that doesn't exist in the clinical setting because we can prevent it. We match the organ and the recipient ahead of time so that the possibility of pre-existent antibodies is excluded. And we see these only when some horrible clerical mistake is made. And an organ from a person of a given blood group, for instance, that was meant for someone else is mistakenly given to another recipient. So I do not expect questions on the USMLE depicting the hyperacute rejection. The second type of rejection is the one we see most commonly, the acute rejection. In fact, almost every single patient who receives an organ transplant has at least one episode of acute rejection that we have to identify and treat. For the most part, we're now talking about an episode of rejection that will happen within a week or 2 or maybe 3 of the transplant. This rejection, with a couple of exceptions I'm going to mention, we're alerted to the presence of this by a decrease, a deterioration in the function of the organ that has been transplanted. As a rule, we diagnose it with a biopsy of that organ, and we treat it with a steroid bolus or anti-lymphocytic medication. But there are two important exceptions that I need to point out. One of them is liver transplant. From a technical viewpoint, a liver transplant is the most difficult transplant to make. It requires removal of the existing liver and many anastomoses of the new liver, the portal vein, the hepatic veins, the hepatic artery, the biliary tree. From a technical viewpoint, it's not unusual for a liver transplant to take 10 or 15 or 20 hours to do. It's not unusual for the blood loss to amount to 10 or 20 or 30 units of blood. So technically it's very challenging. But to our delighted surprise when we began to do them, we realized that the liver immunologically is very well tolerated. It can, of course, elicit rejection episodes, but it doesn't do it very badly and to a great extent. And the bottom line of this comment that I'm making is when we have done a liver transplant and we see the liver function deteriorate on this organ that has been transplanted, our first thought is not rejection, it's technical problems. And we begin the workup not by putting a needle and getting tissue for a biopsy, but by doing essentially sonograms and Doppler studies. We verified that all of the vascular anastomoses are functioning well, that the biliary anastomosis is functioning well, and only when we have excluded those do we say, well, it must be then a rejection episode. And the second exception is a heart transplant. If we wait for a heart transplant to show signs of deteriorating function, it's too late to save that organ. And so patients who receive a new heart get biopsies of that new heart on a scheduled basis. A little catheter is put down the jugular vein, superior vena cava, right atrium, to the right ventricle of a transplanted heart. The teeny bitty bite of tissue is taken. The pathologist looks at it. And it is by looking at the specimen on a scheduled series of biopsies that we identify the beginning of a rejection episode and treat it. And then there is a third form of rejection, chronic rejection. We see this a year or two after the rejection was done. Poorly understood, it has no therapy that we can use. When it happens, all we can do is get a new organ for that person. However, when we see one of these, which will be heralded again by a decrease, a deterioration in the function of the organ that had been transplanted, we do a biopsy. Because every now and then we see a very late episode of acute rejection. And if that's the case, we can reverse that with the steroids or the anti-lymphocytic medication. Let's read a few examples. Vignette number 2. 10 days after liver transplantation, levels of gamma-glutamyl transferase, alkaline phosphatase, and bilirubin begin to go up. There is no ultrasound evidence of biliary obstruction or Doppler evidence of vascular thrombosis. And only because of that last couple of lines there that say we have already checked for the technical problems, only because of that, it is that your answer here would be, well, it must be an acute rejection episode. It's in the right time frame. And you would then recommend on this vignette, let's do a transplant biopsy. Let's do a liver biopsy of that transplanted organ so that we can verify that it is an episode of acute rejection and treat it. Had you had only the first line and a half here, the diagnosis would have been probably a technical problem. Check all those anastomoses. Vignette number 3. On the third week after a closely matched renal transplant, there are early clinical and laboratory signs of decreased renal function. This has to be an acute rejection episode. Biopsy that kidney. 2 weeks after a lung transplant, the patient develops fever, dyspnea, hypoxemia, decreased FEV1, and interstitial infiltrate on chest X-ray. This must be a rejection episode of that transplanted lung. Let's do a biopsy of it, which we do trach. And then finally, vignette number 5. Several years after a successful, and this could be renal, hepatic, cardiac, pulmonary, any of the solid organs that we transplant, there is gradual, insidious loss of organ function. Now this is a time frame for the chronic rejection. But as I pointed out before, the biopsies indicate we may get very lucky and have a late episode of acute rejection. I have one picture to show you. In fact, it doesn't relate to any of the topics that I reviewed with you, but it's such a good picture that was obtained for me by the Kaplan staff that I want you to see it. It's a graft versus host disease. I didn't talk about that, but if you were to encounter this picture in a question, and the question is about a patient who's received a transplant, this is the way the graft versus host disease looks like. And that's the end of our chapter devoted to transplantation.